Hello, my name is David Brown, and for Penn State University's Stat 507 course in epidemiology, I will be presenting an interventional study proposal on preventing central line-associated bloodstream infections in hospitals with limited resources by focusing specialized staff on the most at-risk patients. As modern medicine has progressed, numerous invasive techniques like the use of catheters and ventilators have been developed to treat patients. While these procedures improve quality of care and save lives, their invasive nature provides an avenue for the entry of harmful pathogens. When an infection arises as a result of clinical care, it is known as a healthcare-associated infection. The Center for Disease Control monitors 4 common HAIs: central line-associated bloodstream infections, or CLAB-SI, which is the focus of this study proposal, catheter-associated urinary tract infections, surgical site infections, and ventilator-associated pneumonia. Despite detailed guidelines, extensive efforts on the part of healthcare providers, and the attention of the U.S. Department of Health and Human Services, central line-associated bloodstream infections remain a threat to the safety of those being treated in a medical setting. According to the CDC, there are approximately 41,000 new cases reported in hospital patients each year. These infections prolong hospital stays and worsen outcomes, with nearly 1 in 4 dying after contracting the CLAB-SI. It is important to note that all of these infections are preventable. Greater attention from organizations and better adherence to evidence-based standards has improved rates over the years, but there is clearly still more work to be done, and the growth of antimicrobial resistant pathogens like MRSA and CRE only brings more urgency to the situation. As mentioned, central line-associated bloodstream infections are a specific subset of healthcare-associated infections monitored by the CDC. Bloodstream catheters are medical devices that allow healthcare providers to quickly deliver intravenous medicine and collect blood for tests and diagnostics, but the continuous opening risks infection. Unlike the common IV placed near the wrist, central lines, or CVCs, access major veins near the heart and can remain in place for weeks or months at a time, increasing the risk. To avoid infection, central lines require careful and sterile insertion and regular maintenance. During insertion, hand hygiene and skin antiseptic is obviously required, but best practices also require sterile gloves, caps, and gowns. Further, it is preferable to avoid using the femoral vein if possible, particularly in obese patients, since this part of the body is more difficult to keep clean. Maintenance is also important. The central line needs to be visually inspected regularly to check for loose or unsanitary conditions. Dressings need to be changed, and the permanent components of the central line need to be disinfected. Scrub the hub is the common refrain here, as disinfection of the hub as well as other components requires a vigorous 10 to 15 second scrub with chlorhexidine and alcohol. Finally, an assessment of the need to keep the central line is regularly required so that it is not in place longer than is medically necessary. These steps may not seem overly demanding, but healthcare professionals are notoriously overworked. Even the most professional and conscientious staff can slip in such a setting and risk introducing a new infection by not following proper procedures. Anyone who is treated in a healthcare setting is at risk for developing an HAI, but there are some risk factors. A meta-study published in 2017 in the American Journal of Infectious Control identifies several. Not surprisingly, the meta-study identifies comorbidities like diabetes and other immunosuppressed conditions as a risk factor for developing an HAI. Additionally, healthcare setting choices play a role. Intuitively, the longer a patient is exposed to the ICU and a central line, the greater the risk the patient has for developing a central line-associated bloodstream infection. Others published studies show that practices like hand washing, adherence to checklists, reminder systems, and even well-thought physical layouts can reduce infection risk. But these efforts can require time and money, which low-resource hospitals simply do not have. Literature suggests that a dedicated staffing model can be effective in reducing the incidence of central line-associated infections. In such a model, there is a team of doctors and nurses whose sole responsibility is to insert and maintain central lines and champion best practices amongst the rest of the staff. While effective, this is costly, and hospitals in low-income and rural areas may not have the resources to build such a team large enough to serve all of their patients. From the meta-study, we know that certain patients are at greater risk than others for acquiring a central line-associated bloodstream infection. These patients have comorbidities and have prolonged exposure to invasive medical devices. The following proposal study aims to determine if a smaller dedicated CLAB-SI prevention team can reduce the total incidence of CLAB-SIs in a more cost-effective manner by focusing only on high-risk patients. To conduct such a study, a scorecard that assesses an individual's patient risk of developing a CLAB-SI would need to be created based on known risk factors. The details of such a scorecard are important but out of scope for this presentation. Using the scorecard, the dedicated CLAB-SI prevention team could focus their efforts on the top quartile of high-risk patients for central line insertion and maintenance. For the proposed study, smaller CLAB-SI prevention teams will be created in hospitals with limited resources that do not have the ability to create full staffs that have shown efficacy in literature. Locations will focus on hospitals in rural and low-income areas. Discussed in the next slide in greater detail, the study will need multiple centers, so hospitals should be selected from a diverse geographic area in order to best translate to the country as a whole. The dedicated prevention team will focus their efforts in central line insertion and maintenance and only the top quartile of patients according to their risk assessed by the scorecard, in an attempt to see if this focused prevention can be a cost-effective means for reducing CLAB-SIs. Because hospitals already report CLAB-SIs and other HAIs to the CDC, there is no need to change any data collection processes in participating study centers, and the data gathered for the CDC's National Healthcare Safety Network report can be directly used in the proposed study analysis. To test for efficacy, a statistical test of two paired proportions, specifically McNemar's test, is to be used. The metric of interest is the incidence of CLAB-SI per 1,000 CBC days, and the comparison will be between the prior year and the year following intervention, making this a paired pre-post analysis. Because we only expect the dedicated CLAB-SI prevention team to improve rates, it is to be a one-tailed test, and we will use a standard power of 0.8 and an alpha level of 0.05. We also assume the effect size is a 50% reduction in CLAB-SI incidence. Based on data from the 2017 CDC National and State HAI Progress Report, the current incidence of CLAB-SI is about 1 infection per 1,000 CBC days, which is steadily declining as care improves. This data also suggests that there are about 7,500 CBC days at the average hospital, so we can assume about 2,000 CBC days for the high-risk quartile. With the above assumptions and target incidence of 0.5 infections per 1,000 CBC days, 19 participating hospitals are required for sufficient sample size. This is about 37,000 total CBC days in both the pre and post period. To account for noncompliance and turnover, 25 hospitals should be recruited for participation in the proposed study. McNemar's test requires aggregating data into a 2x2 contingency table where the counts and proportions for each outcome are assembled. We aggregate the number and proportion of CBC days both with and without an active CLAB-SI in the pre and post period. If the intervention of the small and targeted CLAB-SI prevention team is ineffective, then the proportion of successes in the post period will be less than or equal to the proportion of successes in the pre period. In this situation, we do not reject the null hypothesis. However, if we determine the post-period proportion of success is statistically greater than the pre-period, then we reject the null hypothesis and conclude the intervention was effective in reducing the incidence of CLAB-SI for any given CBC day. Like all studies, this proposed study has strengths and limitations. As a strength, the pre-post design helps control for many confounding factors, since the hospital's pre-period serves as its own control. Most aspects of care within a given hospital should be consistent from year to year. Also, a strength is that the study design requires no changes to existing data collection efforts. Finally, the study respects that financial considerations are important for resource-constrained hospitals. As a limitation, the study design does not consider the ongoing downward trend in C-Lab SI incidence that has been observed over the years. As a result, a significant effect may be observed even if it is not due to the creation of the prevention team. Also, the analysis will only determine the effect of a small prevention team over no additional staff at all. The difference in efficacy between a small team and the suggested full team in literature will still be unknown. Finally, this will be a suboptimal solution no matter what, as a full dedicated team that serves the entire patient population will always be the ideal case. In conclusion, this proposed study has merit because it's important to understand cost-effective ways to reduce C-Lab SI in low-resource hospitals. As long as hospitals have finite resources, every staffing decision is a trade-off, and finding the optimum instead of the ideal is necessary. If effective, this small C-Lab SI prevention team that focuses only on high-risk patients could serve as a model for the best way to provide care for hospital patients as a whole, if it means a better use of resources. Thank you for listening. I hope you found this presentation informative and interesting. Provided here is a list of references used for the information and data in this presentation, all of which have extensive subheadings and further reading that may interest the curious reader.